All right, so we'll start off just by defining a taper. So it's a connection that facilitates intimate contact between a conical trunnion, which is the male component, and a conical bore, which is a female component. And by the stress transferred from the trunnion, it imposes compressive stresses on the walls of the bore and therefore providing rotational stability. And the main benefit it will give you is the modularity, as we've seen in many of the revision talks. That's where it comes into its own. Most of the tapers we use are a Morse taper, but they do differ significantly in the length of the contact, the diameter, and the surface texture. So we're all familiar with the 1214 taper, but one 1214 taper from one company is completely different from another from a different company. They vary in their angles and in their lengths as well. So it's not standardized. Of course, there are company-specific tapers like the V40, which is specific to the Stryker group. This is a surface topography study from a group in Sydney, Bill Walter and Bill Walsh, who studied the surface topography of commonly used stems. And you can see there's a marked difference in the pattern of the taper itself. They largely divided the tapers into two groups: a non-threaded taper, which is largely featureless. It relies on small micro peaks and valleys to achieve good contact points between the taper and the head that it's impacted on. And the second group is more of a threaded surface finish, where you see large peaks and large valleys, and it's a repetitive kind of pattern. And the idea here is, as the head is impacted on, these peaks flatten out, creating more even contact areas. So you can see that not only does the taper differ, but even within one manufacturer, the taper is completely different. This is a comparison of the Karai in green and the Ezron, both manufactured by the same company. And you can see that one uses a threaded philosophy, whereas the other one is quite smooth. So it does differ, and it differs significantly. Now, what do we worry about in terms of taper? We worry about taper corrosion, which is this dreaded black material that we see. And of course, we worry about catastrophic failure. And if you think to yourself, well, this seems to be something new that we're hearing about, well, you're right, because tapers were initially introduced in the 80s, modularity, was introduced in the 80s, and the first revision for corrosion was in 1988. And of course, with any orthopedic material, we see the failures come in after they've been used for a significant period of time. So after 2010, you see an explosion in the literature and the reports of taper corrosion because they've been used for a significant period of time. So I thought I'd just touch base on what is corrosion. When you put a piece of metal in the body, there is a natural body reaction. It basically forms a protective oxide layer, assuming that it's in an oxygen-rich environment. And that's not bad. That's actually quite good. It's protective for the material that you're using. That's called passivation. Now, with use, with motion, such as fretting, you can get damage to passivation, but the implant still has a capacity to achieve another oxide layer, and that is called repassivation. The problem is when you don't have enough oxygen in that environment, such as in the little crevices that are around the taper, then you have an environment where essentially a battery is set up, where we have flow of electrons and creating in that an acidic environment where we get breakdown of material, and eventually this leads to the deposition of, in this case, chromium phosphate salt, which gives the black tarry appearance. Corrosion has many factors that lead up to it. It could be mechanical, it could be chemical, or it could be even from the type of metal it's used. We see the sequelae, which are early septic loosening, osteolysis, the presence of radiolucent lines. We also see tissue reactions develop. And of course, what we worry about is the implant failure, especially common with the dual modularity type implants, which have largely been abandoned. If we look at the Australian registry experience, some sort of metal problem appears to be the cause behind revision in hips between 5 to 10% of the cases. I'm going to use the example here of exchangeable necks. I know we don't use this kind of hip anymore or commonly anymore, but I want to use it to highlight a few things, a few aspects. So if we look at the registry supplementary report, it reports on exchangeable and fixed necks, and we can see that the revision rate is much higher for exchangeable necks compared to fixed necks. And that's regardless of what type of bearing is used. So in green here we have the exchangeable necks, and in blue is the fixed necks, and we can see that it's always higher. And a component of this early failure rate is because of the corrosion, the earlier corrosion. And it also has to do with metallurgy. So a lot of these components have a chrome cobalt component with a titanium neck, and then we can see that the different metals lead to increased corrosion and increased failure compared to a titanium construct. And that same relationship applies regardless of what the type of or mode of failure is. So what are the factors associated with it? Well, obviously obesity doesn't help, and implantation time. So the longer the implant is in place, the more likely it will suffer corrosion. But there are also design components like shorter taper lengths, narrower tapers, and a reduction in the neck profile, which has largely been used to reduce the issue with impingement. Decrease in the rigidity of the component is being used to allow for more compatibility with the elastic modulus, but it does reduce the taper rigidity and lead to more stresses on it and more risk of corrosion. Femoral head size seems to play a major component, and offset also seems to have a component. We talked about metallurgy. Ceramics seem to be more protective, however, Xenium doesn't seem to have any added effect. And the way you impact the taper is important. You need a dry environment to impact it to increase your contact areas, and you have to give it a fair whack. 4 kilonewtons is the minimum recommended there. What happens in corrosion? Well, you generate biologically active debris, and a type 4 hypersensitivity reaction develops, leading to the tissue damage. Because corrosion doesn't generate as much ions and metal debris, I guess, compared to metallosis, you get preferential or differential presence of elevated metal ions in the blood. Cobalt is more soluble, so it tends to leach into the blood and be detected in higher levels in the serum compared to cobalt. So you can test metal serum ion levels, however, and there's no precise level at what you should be performing a surgery. So it's a clinical decision when you have an elevated serum level of cobalt, unexplained hip pain or stiffness, together with exclusion of sepsis, and that can be a reason for revision. And you can aspirate the joint and test it for chrome and cobalt levels. And you can perform other investigations such as X-rays or metal suppression MRIs. Hip arthroscopy has been recommended in some papers, however, I have no experience in doing that before revision surgery. Now, Goldberg devised a classification which is largely dependent on the amount of surface area involved and how much damage there is to the trunnion. Essentially, what you look at is replacing it, as we've described before, with a sleeved head. You can consider ceramics. And if you're going to reuse a metal head, you should probably use a titanium sleeve as well. Thank you.
Right.